All right, guys, it's 1 o'clock, so we will go ahead and get started. So, want to welcome you guys back, and for Recovery Solutions, treatment for addiction, trauma, and co-occurring disorders. Real pleasure for me to be here with you guys this afternoon and talk to you about this subject matter. Um, give you a sense of what I'm going to be covering for you guys. We're going to talk about trauma and specifically post-traumatic stress disorder and some real strong emotions that come along oftentimes with PTSD, trauma, and substance use disorders, which is shame. And, why is that a toxic emotion? We'll get into talking about recovery capital and how do we help our clients increase their recovery capital, and talk about some principles for co-occurring disorders. So when you're trying to help an individual that's struggling with a mental health and a substance use disorder, what are some evidence-based practices that have been found to be really effective in trying to help them? And lastly, we'll end up talking a little bit about spirituality. Please, while I'm going, if you guys have a question, stick your hand up, fire away. And I'll make sure at the end that we also have a little bit of time for questions as well. So, when you think about, what's the lay of the land? Okay. What are things like, in the United States around this subject matter? In 2021, among those age 12 or older, we had about 161 million people that used tobacco, alcohol, and illicit drug in the past month. Okay, that were deemed to be current users. So 161 million, a little more than half the population, including 47.5% who drank alcohol, almost 20% who used a tobacco product, and 14% who used an illicit drug. So that's a large population of individuals using some type of a substance on a monthly basis. Among the 133 million current alcohol users, 12 or older, 60 million were past month binge drinkers. Okay. What's binge drinking? 5 or more drinks at one sitting. When you go back to, the impact of COVID and what we saw there and the increase of alcohol consumption in our country, it's one of the big reasons why we're at a place that we've never been before. At the end of 2022, we had a 50% increase of Americans that made it to a liver transplant list. Okay, let me say that again. A 50% increase of Americans that made it to a liver transplant list. That's how much drinking was going on, in 2021, 2022, right? It's a place we've never been before. Percentage of people who were past month binge drinkers was highest among young adults, age 18 to 25, followed by adults age 26 or older, and then by adolescents. And that, that especially coming out of COVID, that makes a lot of sense that we're seeing that. And we don't want to forget about alcohol. Oftentimes we talk about, opiates, heroin, now fentanyl, and it makes sense. One-time use, somebody's life's over, right? You look at, 109,000 overdose fatalities. Now we're starting to make progress in decreasing that. At the same time, though, alcohol will always kill more people. Every year, alcohol kills more people in our country. It's just slower. It's just much slower. The excessive alcohol use was responsible for more than 140,000 deaths each year during 2015 to 19, or more than 380 deaths per day that we have in the United States around alcohol. Without substantial changes in drinking culture or interventions to address high-risk drinking, the disease burden and deaths due to alcohol-related liver disease will worsen in our country. Additional interventions are urgently needed to reduce mortality and morbidity associated with alcohol-related liver disease. The fastest states, as far as experiencing cirrhosis in liver, who's number one? Kentucky, 6.8%. It's really woven into our state. I mean, it's one of the biggest parts of, from a financial standpoint. We've got the Bourbon Trail, we've got distilleries everywhere. We've got, there's a big payoff that comes from it. There's a lot of positives that come from it. At the same time, there's a lot of serious repercussions that come from it as well, unfortunately. And we're continuing to see that increase. When you look at what are called deaths of despair, okay, what are deaths of despair? Suicide. We had the highest rate of suicide last year in the United States since the Great Depression. We lost almost 50,000 people related to suicide. So suicide, overdose, okay. We did better 2023, but 2022, almost 109,000 overdose fatalities. and alcohol-related liver disease. Individuals that we lose related to chronic pancreatitis, cirrhosis, liver disease, and all the things that come along with that, cancer related to alcohol consumption. It's really significant. Among the almost 18 million adults aged 18 or older in 2021 with co-occurring any mental illness, depression, anxiety, bipolar disorder, and an illicit drug or alcohol disorder, about 52% or 9 million received either substance use treatment at a specialty facility, residential, inpatient, detox, or mental health services in the past year. So that's progress. That's good. A lot of people did get some help. We still have a long way to go though. Okay. So I mean, again, at best half. And these are the individuals that we know about. These are the individuals that like show up. These are the individuals that call. We can look at data from Medicaid, private insurance companies. We can look at CPT codes. We can look at, diagnosis to know who gets services. But I'm in a room full of people that know very well that's just scratching the surface of who needs it. There's a huge gap between who gets it and who needs it. Among adults aged 18 or older with any co-occurring mental health and illicit drug problem who received either service in the past year, most 84% received only mental health services. So let's think about that for a second. I have a co-occurring disorder. I have significant alcohol use disorder and depression, right? 8 out of 10 individuals are going to get seen for mental health, but that's it. Nobody's going to ask me. Now they may ask me and I may say I don't have an alcohol problem, but most often I'm not going to be asked about it. I'm depressed. Here's what's going on. And unless somebody's doing a pretty good assessment, it might not even come up, And that's not just, what happens in the treatment field. Okay. I guarantee you, the local hospital here, this is going to happen today. A 48-year-old adult male is going to show up with a head laceration. Okay. They're going to say, well, what happened? And somebody's going to say, man, I was in my garage and I fell off my ladder. Well, you got to watch those ladders. They're going to stitch me up and I'm going to leave. That's a lie. Okay. I was under the influence. I tripped over the dog and busted my head on a table. And that's why I'm there. Things like that happen all the time related to alcohol. When you look at, who shows up at a trauma center, okay, about 58% of people that make it to a hospital trauma center test positive for a substance, and oftentimes multiple substances, have alcohol, marijuana, Xanax. So that's fairly common that we see. It wasn't until probably about the last 10 years that we've gotten better at doing things like SBIRT, which is screening and brief intervention and referral for treatment. So, if you show up at UK's trauma center, okay, and there's 2 people I know for sure because I supervised them there, and you test positive, Jason is going to show up in your room at some point when you come to and say, hey, my name's Jason. I'm an alcohol and drug counselor. And I noticed you tested positive for a substance here with your compound fractured leg from your car. Would it be okay if I ask you some questions about it? And hopefully that person says yes. And Jason's going to do a brief intervention because the research shows the chances of that person going into treatment go up dramatically if we catch them when they've just had a traumatic incident. But if nobody's there to ask me about why I tested positive, I'll get better. And what's going to happen? I'm going to leave and keep drinking, or use substances more than likely. So it's good we have that. So let's talk about trauma, PTSD. So post-traumatic stress disorder. There's some hallmarks or tenets of this disorder, PTSD. One, that it involves trauma, obviously, right? And trauma takes on all kinds of different forms, fashions. I say the word trauma, you get an idea in your head about that, what that's like. But it's very different for different people. And what makes something traumatic for one person may not be for somebody else. But oftentimes it involves intrusion of thoughts. It's things I don't want to think about. It's things I don't plan to think about. There's avoidance. I don't want to experience this. I don't want to have thoughts about it. It affects my thinking. It affects my mood. It may cause a change in my arousal state or reactivity. Okay. This kind of hit home for me a little bit because you guys maybe saw this in the news or not, but at the high school where my kids went, okay, they had a death over the weekend. Okay. They were out on Richmond Road in a lake, group of kids. It's a birthday party. They're out in the water. Okay. The 16-year-old that's good friends with my daughter, she's giving him rides. He's a big part of the school where he goes. He goes underwater. He's just hanging out. It's 5 feet of water. Okay. They're all hanging out, bunch of girls and guys. Nobody's using substances, nothing like that. It's a birthday party. He doesn't come up. They all start freaking out. They all start trying to find him. Nobody can find him. They call EMS. He was in the water for 35 minutes before they pulled him out. He died, you know? So you think about the trauma for his family, okay, who weren't there. You think about the trauma for the kids in the boat and the kids that were around trying to find him. These are all juniors, seniors in high school, watching him being taken out of the water. They've all experienced that, seeing EMS come up, being questioned, what happened. So and then, man, we live in a world. How long did that take to get out on social media? Okay. So my daughter was spending the night at our aunt's house in Louisville, and I got a call at 10:30 and she's crying. We lost him. I'm like, what happened? So that made the news in Lexington at about 11. It happened at 8. She called me at 10:30. So now she's experienced this. And then you've got the whole school. You see what I mean? So it's going to be very different for different individuals and their relation to it. And that's a unique thing about trauma too. We always want to keep in mind. Direct exposure. I was there. I experienced it as a witness. Learning that it happened to someone else, there's trauma that comes along with that. Man, you look at how many natural disasters it seems like we have now related to weather. I mean, you guys probably saw in Iowa, I think 9 people died from tornadoes a couple of days ago or yesterday. So many people injured. It seems like every week there's some type of a weather event where so what's the impact on that in a community? Kentucky, the flooding that we had where, loss of life, and man, the impact of everything that you have, you watch it disappear. All the memories, you can't stop it. It's shocking. It's uncontrollable. And that's trauma. Exposure to aversive details, for sure. So distressing memories are part of post-traumatic stress disorder. And that's a real hard one because, all of us in this room, we've got a hippocampus. Okay. Well, what's important about our hippocampus? Its job is to store emotional memories. Okay. That goes back to caveman times. That thing eats us, run. Okay. Pick that up and eat it. That's good. And its job is to store those memories basically to help us stay alive. However, when something traumatic happens, it stores that memory as a warning. Watch out for this, but I can't control the reaction I'm going to have to it. So if I'm a first responder and I experience something, if I suffered some type of abuse, I'm going to have a stored memory about that my brain is going to bring up periodically as a warning, but that may happen randomly driving down a road. It may happen walking through a mall. It may come out of the blue because I smell something that triggers it, and that's all my brain going, pay attention, pay attention. But it also means I may feel like I'm coming out of my skin. I'm anxious. I'm having a panic attack. My mood's depressed, and we can't necessarily control that. I may have nightmares about it, That's interesting too, because what happens, I'm up and I'm awake and I'm alert. And my brain's like, okay, we're okay. Everything's good. We haven't seen anything, but then I go to sleep and what's my brain do? Whoa, pay attention, pay attention. So subconsciously, I'm going to have a nightmare. I want you to remember this, You guys ever had those nightmares where you wake up and you're like, man, is this real? Did something, like it takes you a while to snap out of it? That's our subconscious and conscious making sure you're paying attention to something, and that can lead to some pretty intense distress. Physiological reactions, coming out of my skin, shortness of breath, sweating, heart palpitations. I had a new client I picked up not too long ago. I said, tell me what got you referred to me. And he's like, my $10,000 anxiety attack. I'm like, well, tell me about that. He's like, man, I was having a heart attack. I knew I was having a heart attack. I felt it in my chest, my arm, everything. I went to the emergency room. Man, they hooked me up, EKG off the bat, blood draws, everything. He didn't have any health insurance at that time. Okay. Full CAT scan, all this stuff. He's there for 5 hours. The doctor comes in. He's like, well, I got good news and bad news. Which one do you want first? He's like, well, man, I guess, give me the good news. The good news is from here down, you're the healthiest person I've seen on this shift. What's the bad news? From here up, you need to talk to somebody. You've got anxiety. You've got panic. He's healthy. Okay. But that was the physiological reaction to a traumatic reminder that he hadn't experienced in years that brought all this on, and that's post-traumatic stress disorder. So avoidance, we want to avoid things, and listen, that makes sense. I mean, when you think about most of us, if there's something that makes us anxious, what do? We push away from it. We don't want to be by it. One of the best treatments for it is to do what? The opposite, go toward it. Because if I go toward it, I'm more likely to cope with it. But there's a lot of fear that comes with that. That's a big risk. What's my comfort level? What's my skill set? What's my confidence in being able to do that? So avoidance is fairly common with PTSD. I want to avoid external reminders. Some of that is really, really difficult because again, it comes back to brain functioning. I had a client with pretty significant PTSD that was in Iraq. He did 2 tours in Iraq. Okay. And when he first got back to the United States, he really struggled when it came to driving. In fact, he had his first full-blown panic attack when he got behind the wheel and he got out to his neighborhood and he was getting closer and closer to a stop sign. And in Iraq, you don't stop. You don't stop. I mean, the only time you stop is if everybody stops and there's a really good reason, because what happens if you stop in Iraq? You're either going to get blown up, you're going to get shot at or whatever. Well, man, he had a full-blown panic attack when he had to stop, he just couldn't do it. So, and walking into a store like Walmart, where it's like, okay, I don't have anything behind me. I want my back against a wall. I want to know who's coming around. Well, you're not having that at Walmart, So how do you adapt to, and man, if I don't want to experience that, I'm going to avoid it. So sometimes there's inability to remember parts of the trauma. And even though we might think, well, isn't that a good thing? At the same time, to recover and get through it, oftentimes you process through it. And that means you do remember some of it to normalize it and to get to a point where you can cope with it better. Sometimes the inability to experience positive emotions comes along as well. A lot of clients will talk about feeling anhedonia, like things that used to give me a lift. It just doesn't do it. Walking the dog, hanging out with my kids, going somewhere with my spouse. Man, it just doesn't give me the lift that before it did. So changes in cognitions and mood, sometimes that can get into, blaming of self. Why did this happen to me? Why did this happen to me? Which makes sense. Yeah, I mean, man, so many really freakish, traumatic, life-changing things can occur just on a day-to-day basis, like the story I started off telling with you guys. How did that happen? It happened. It was a freakish event that occurred. And there's a lot of blame that can occur for people, that comes along with it. Negative emotional states, diminished interest and participation, things that used to lift somebody's spirits, they stop doing, which is one of the worst things we can do. Hobbies, interests, stuff like that lifts our spirits. That's a big part of who we are as a human being. And that's one of the devastating effects of a substance use disorder. When it gets to where my brain wants this substance more than this other thing, I'm in trouble. I'm giving up day-to-day activities to lift my spirits because of the effect of fentanyl or cocaine or alcohol. Detachment and estrangement from others. Isolation comes into play a lot. There's a lot of, worry and fear around being around other human beings, especially if the trauma is related to that. Okay. Let's talk about that for a second. there's a good percentage of individuals that will experience acute trauma, which is a one-time traumatic event, an assault, rape, a divorce, loss of a home, some type of natural disaster, acute trauma. Then there's individuals that experience chronic trauma, which is repeated traumatic events, right? Think about our first responders, chronic trauma. I had a client several years ago that came to me with PTSD, and for 15 years, he was a primary OSHA investigator. Okay, what's that mean? Any fatality at a major place, he showed up first. A human being that got swept into machinery, that's him. Pictures, talking to the family, 15 years of doing that. How does your brain, and finally he just couldn't do it anymore. He had a full-blown panic attack, everything else, and he had to leave the job. Yeah, that makes sense. Our brains aren't programmed to know what do you do with those type of experiences. So chronic trauma. Then there's what's called complex trauma, which is trauma done to me by a loved one. So here's a human being that I look to for love, trust, and understanding, and they're sexually abusing me. Here's a person I look to for support, like in a parental role, and they're abusing me in some fashion. That type of trauma tends to have the most lasting effect and the most difficult effect on human beings. And that can also lead to a lot of negative beliefs and expectations too. Arousal and reactivity. So, when something occurs, how do I react? That could be everything from tearfulness, depression, irritability, anger, rage, anxiety, panic, reckless or self-destructive behavior. Here comes substance use oftentimes. Hypervigilance may come into play. Exaggerated startle response may come into play. I was doing a ethics training a couple months ago, and a lady stuck her hand up, and we were talking about how inadvertently we can re-traumatize people. And she said, I had a new kiddo. This was at a psychiatric PRTF. So this is a residential program for age 12 and under, that have significant behavioral issues and mental health issues. I did my assessment with him yesterday. It went really well. He was 8 years old. We talked about how I can help him, everything else. The next day she comes in and she walks into the gym and they're doing a recreation activity. She's like, well, this is cool. I'm going to go up and be a part of it, right? And there's 12 kids in there and she sees her kiddo, okay? And they're all kind of in a half circle facing the instructor, right? And she said, that's where I made my mistake, okay? I walked up behind him. He was on the end and I gave him a side hug. And he completely came out of his skin. He started swinging and he was yelling. And she's like, he was victimized by physical abuse from a perpetrator. And I basically came up and surprised him and re-traumatized him, by not, we need to ask permission. Would you like to be hugged? We need to ask permission. It's better to come face forward so they can see who I am. You see what I mean? She didn't intend for that to happen, but it happened. And that's where, ultimately, a part of what I hope you guys take from this is, you're going to hang out and hear about this for a couple hours. You're going to be a little bit more trauma informed, and trauma informed care is, I'm always assuming that everybody I interact with is a trauma survivor. If I do that, I'm going to do better with them. It'll be a better relationship. It'll be a better outcome. Therapeutically, it will be better because I'm going to keep those things in mind. If I don't assume that, like that person, I can make a mistake, and that can happen. High levels of comorbidity. So with PTSD, oftentimes there's going to be depression. There's going to be anxiety. There can be personality issues that come along with it. There oftentimes is substance use disorders that come along with it. So we know diagnostically, somebody that's experienced trauma, they have a higher chance of having a comorbid depression, anxiety, and or substance use disorder. So, and that also gets into what's called complex post-traumatic stress disorder, which is PTSD with difficulties around affect regulation. I have a hard time controlling how I feel, okay? I wake up and I could be in a rage. I could be deeply depressed. I could be calm. I could be worried. I could have panic when I wake up. It's just, you never know what it's going to be like, which is pretty scary. I have pretty negative beliefs about myself. So, all of us in this room, we have a normal self monologue. What do we say to ourselves? You guys have been doing it all day today. You're doing it right now. But for the individual that has complex PTSD, usually it's pretty negative, and it's a negative view of self. What's wrong with me? Nobody loves me. Who would want to be with me? It can be really self-loathing. And then lastly, that leads to disturbances in relationships. Oftentimes I struggle in relationships. Um, would you all say it's more likely for a first responder to have a relationship that ends in divorce or long-term marriage? Yeah. Okay. And a lot of what I'm sharing with you is because their risk of experiencing these things is much greater, and that's going to take a toll on a relationship. Okay. Um, so some other consequences of trauma exposure, a lot of these events are very defining for the person. They're life-changing moments. When you hear people say they're never going to be the same, that's oftentimes the case. Regardless of whether they go on to develop PTSD or another trauma-related disorder, they're going to be different. Okay, think about Dr. Mooney. I mean, I remember when that happened. I remember Kathy calling and saying, "You won't believe what happened to Dr. Mooney." But I mean, you're driving down the road and something like that happened. I mean, you talk about having a higher power, but that's a traumatic event, and how you handle that and the repercussions of it and the recovery and everything else that he's still going through, and a huge advantage he has is his recovery experience, and the supportive network around him that makes a huge difference. But whether it's a one-of event or more prolonged trauma, it shapes somebody's view about not only themselves. You heard him describe that. How it's changed his view of self. Our world around us, for a lot of individuals, the world becomes a lot less safe. It doesn't become more safe; it becomes less safe. And how they relate to it. How do I relate to other human beings? Can they be trusted? And that gets into helping environments. What's the environment like? Okay. Show of hands, how many people here work in a residential program? Okay. How many people work in inpatient treatment? How about outpatient? Okay. Any detox folks? A couple people? Okay. Listen, a bunch of different hands went up for different environments, but regardless of that, when the new client walks into your environment, okay, and they've experienced trauma, there's a lot going on with them about your environment. It's what it looks like, smells like, feels like, sounds like. It's what their interaction is with you. How do you react to them? All of that comes into play. For 14 years, I worked for an inpatient psychiatric and chemical dependency hospital. I mean, individuals that are coming, it's one of their worst days, right? And the level of trauma was really significant, especially when you think about child inpatient psychiatric unit, adolescent boys and adolescent girls inpatient psychiatric unit. So a lot of the training that I would do for new employees is, do you understand trauma? And do you understand simple things like vocal, how you say things, your tone of voice, your cadence, your proxemics, how you walk in, where are your hands, how do you stand? Some of those things can make a huge difference in somebody's fight or flight or freeze kicking in off the bat, or they're going to be okay with me. So that's trauma informed, is do I understand that and keep that in mind. Some of you all have heard of Dr. Gabor Mate, excellent physician, been around a long time, that's done a lot of great training and published a lot of great stuff. But I like these couple of quotes here. Emotionally draining family relationships have been identified as risk factors in virtually every category of major illness, from degenerative neurological conditions to cancer and autoimmune disease. Emotionally draining family relationships. Anybody here ever experienced an emotionally draining family relationship? But listen, think about your clients. Think about the clients that you're treating, and what are their family relationships like? What was that like for them growing up? What is it like now? And then, not only that, but hey, how are their family responding to them? but when you think about all the physical things that can come from a toxic relationship, it's really significant. And yeah, when we look at the research that predicts who is likely to become ill, we find that the people at greatest risk are those who experience the most severe boundary invasions before they were able to construct an autonomous sense of self. Okay. Most of the time, that autonomous sense of self doesn't come till 19, 20, 22, 23. You know, you guys that work in residential treatment, if you had to tell me what's the average age of onset of the first time your clients used a substance, what age would you say? 12? Anybody else? 14? Anybody else? Heard somebody say 9? So think about that. I am nowhere close to establishing autonomous sense of self, and I'm already putting a substance in my brain that's going to have an effect on that. So yeah, here they are now. I'm 38 years old and I'm sober, but there's so much arrested development that, man, you're really doing adolescent treatment, because of everything they've experienced, unfortunately. So there's risk for substance use disorder, okay, and with that, especially with PTSD. But overall, what are some tenets of this? Is there family history? So if I have a first degree relative, parent, sibling that has a substance use disorder, that's going to increase the risk of my development of substance use disorder. You guys know that. If I don't have a lot of social support, okay, so lack of family support, perceiving that one doesn't have a supportive environment, that increases the risk of developing a substance use disorder. A lot of our clients have experienced that. Who do they run around with? I was doing supervision with one of my supervisees yesterday, and they picked up a 15-year-old adolescent client, and mom caught him smoking weed. He and some buddies broke into a building, got in trouble, so now he's involved with DJJ. And, we were talking about the assessment stuff. I'm like, something else you really need to make sure you do when he comes back is say, hey, talk to me a little bit about who you're running around with. Man, the guys that got in trouble with you breaking into the building, I don't need to know their name, but just give me their first names. Tim, John, and, Barry. Okay. Well, tell me about Tim. Tell me about John. Tell me, trying to learn, hey, who am I surrounding myself with? Because that part plays a huge role in what direction my life could go. It doesn't take a lot, depending upon some peer influence, to end up someplace you didn't think you'd end up, unfortunately. A history of trauma or abuse. So having a childhood history of emotional trauma, huge risk factor for developing a substance use disorder. We're going to talk a little bit more about that. And then lastly, if I have a diagnosis of a mental health disorder, depression, anxiety, a lot of individuals, I see a lot of clients in my outpatient practice that show up. And inevitably, when I start peeling back the onion of, what do you like about marijuana? What do you like about alcohol? What do you like about cocaine? What's the payoff? It's how I feel. It's my mood. And I'll ask them, hey, when did you first notice feeling depressed? And almost always middle school, high school. They finally get to me at 26, but they've been struggling with how they feel since they were 13. And then here comes drinking at 16, 17, weed, 18, weed, 19, Xanax. By the time they get to 23, 24, they've got a pretty significant substance use disorder. But how did it all start? How I felt. I wanted to change how I feel. And they've been untreated that whole time. So that also puts them at pretty big risk. So a good way to remember this, Cubis. So chemical issue, that's going to lead to some vulnerability. Unresolved issues, so trauma, that oftentimes is suppressed or repressed. My beliefs about myself that tend to be pretty distorted, how I view myself. Yeah, it's good that clients get screeners, so like, for example, I give a lot of my clients a Beck depression inventory and a Beck anxiety inventory. They can fill them out 5-6 minutes just while they're waiting for my appointment, but it gives me a wealth of information, a lot about how they view themselves. So I had a new client a couple weeks ago, and I looked at it, and he scored like a 28, which is not clinical depression, but he's definitely got a mood issue. But some of the things that he circled 3 on, I'm a failure. Okay. 26, I'm a failure. Okay. I'm responsible for all of my problems. Yeah. No, not looking at your history, how he views himself, his appearance. There are a lot of things on there that, and again, if I'm depressed, it makes sense that I'm struggling with that, but I'm going to start with, hey, let's raise some discrepancies about that because it's probably not factual. It's based on this negative construct. And a lot of that stems back from trauma. Inability to cope. So using a substance to cope with trauma. And, unfortunately, a lot of these substances end up having the opposite effect. A lot of individuals with depression, what do? I drink alcohol. Well, what's alcohol? A liquid depressant. So I'm going to put a liquid depressant on top of my depressed brain and think that that's okay, and I'll hear this a lot. Well, it helps me sleep. Well, here's the thing. It sedates. It does sedate you, but it prevents your brain from actually getting into REM sleep. So you may pass out, okay, but you're going to wake up not feeling good. And then what do we typically do? Here comes a monster drink. Here comes caffeine. Here comes all this. And I go through the whole day. I'm kind of wired up. I feel all right. And then what do? I do the same thing at night over and over and over and think that that's going to be okay. And then lastly, the stimulus response relationship. So how does my brain cope with just day-to-day kind of things? A lot of your clients, and I know you guys know this, have experienced adverse childhood experiences. So when you think about ACEs and, what is somebody's ACE score, right? If you're working with a client that has an ACE score that's 4 or higher, they're probably the highest risk client you have for suicide. They're going to be much higher risk for a substance use disorder, much higher risk for PTSD and a mood disorder. So, and these are the ACEs. So, you can sit down with a client pretty quickly and ask, hey, did you ever experience recurrent physical abuse? Yes. Did you ever experience recurrent emotional abuse? Yes. Did you experience sexual abuse? Maybe no. Did you experience neglect? Yes. Did you grow up in a household where there was domestic violence? Yes. Well, there's 4 right there. Okay. How about an alcoholic or drug abuser? Yes. Someone chronically depressed, mentally ill, or suicidal. At least one biological parent was lost to the patient during childhood, regardless of cause. I think I saw this the other day. What is it? We have 375,000 grandkids being raised by grandparents in the United States now. Okay. Most of them lost a parent either to incarceration or overdose. And then lastly, someone in prison. Not have a caregiver because they were incarcerated. So think about your clients and think about how many of them hit on these ACEs, and especially those that are 4 or more. Chances are pretty good they're struggling with PTSD, and they might not even be really aware of it. That's where a good, thorough evaluation would be very, very helpful for them. What else does the prevalence stats tell us? A lot of adults and children that end up in psychiatric treatment settings have a trauma history. We just talked about that. Good percentage of people with substance use disorders have traumatic stress symptoms that interfere with achieving and maintaining sobriety. Okay. Achieving and maintaining sobriety. So when I first started off in the field, I got hired to be a family therapist. Okay. And I was responsible for running a family therapy program for a residential substance abuse place, right? I did all the family therapy, 4 multifamily education groups a week, all the individual family therapy. When I took that job, I'd done 2 family sessions my entire life. It's baptism by fire. Okay. But I loved it. I ended up really enjoying it. And it was, I liked it a lot. But when I would burst their bubbles about, well, when your son relapses, this is their first treatment, the chances of them walking out and maintaining long-term sobriety, okay, it's a relapsing illness. So let's talk about how do you handle if they relapse? That's a symptom of it. But their mindset was they're sober. They're never going to use again, which is unrealistic. I mean, you guys know that's a part of this illness. So, a lot of individuals that walk out of treatment, I'm sober, SOBER, son of a, everything's real. You know what I mean? I feel everything. Best part about sobriety, I get my feelings back. Worst part about sobriety, I get my feelings back. I'm out front after 28 days, sun's on me, and I'm coming out of my skin, craving like I've never craved before. and people are saying life's great, right? I mean, that's just the nature of this, especially when you talk about post-traumatic stress disorder and what that feels like. Good percentage of adults and kids in prison or juvenile justice have a trauma history. All systems of care, and oftentimes they go undetected. That's the other thing. Lots of times they go undetected. And listen, some of that is the client won't tell us, even when we ask. But that doesn't mean I only ask once. As you start to notice things during their course of care, you'll see some symptoms that will arise where it makes sense for us to ask. It seems like something's happened to you. And that's the thing. It's not what's wrong with me. It's what happened to me. Something happened, usually that the person had no control over happening and they didn't want it to happen. So there's that connection. We know, there's a big linkage between substance use disorders and trauma. Okay. They go hand in hand. Real similar to, pain and substance use. If you understand chronic pain, we understand substance use. It's my brain doing its job, which is, hey, don't forget what makes you feel good. Don't forget what's going to help you cope. So the linkages are strongest between substance use, post-traumatic stress disorder. Those typically go hand in hand. Some of you all are familiar with Claudia Black. She's been a guru in the substance abuse field forever. This quote here: if we are chronically dysregulated long enough, we tend to become stuck in a dysregulated state, regardless if the original pain is still present or not. Regardless if it's present or not. So a lot of clients, I became chronically dysregulated at 14, 16, 18, 20. Here I am in your treatment program at 35. But because of my substance use that's been maintained, I haven't gotten to a good coping place with it. And I'm still like I was when it happened, so that expression, the past is never really the past. That's kind of what that's about, that people tend to be dysregulated. So, you look up here, and this is talking about our autonomic nervous system. Okay. On a daily basis, it experiences periods of arousal, okay, and periods of decreasing arousal. I saw it here in this room at 11:59. You know why? Because Kathy got up and said, it's lunch. And all of a sudden there was arousal in the room and you guys stood up and everybody's like, all right, man, something's about to happen. And where am I in line? I'm in the back and that looks like cake and I can't get to it. And all that stuff you all were dealing with. But then you guys got your food and guess what happened? Hey, I'm good. I'm sitting down. This tastes good. Everything's okay. But listen, some of you guys, I know you looked at your phone, crap work. Here comes arousal, right? But then something else happened and you calm down. Right now, for the most part, a lot of you guys seem like this. Okay. And that's just normal day to day. Right. But then, yeah, if you've got kids, if you've got this, that, we know those periods. Okay. That's different with our clients. And in active addiction and experiencing post-traumatic stress disorder, it's different. This is more them, right? So, I am experiencing huge increases of sympathetic hyperarousal, right? Anxious, panic, restless. Where's my therapist? Do I get my pass? What about this? Phone time. Who got my cigarettes? Man, all that stuff that comes along with it. Okay. Exaggerated startle response, night terrors. I'm in a strange environment, flooding, impulsivity, then parasympathetic hyperarousal, flat affect, depression, numb, dissociation in group. And I'm checked out. I'm there physically, but I'm not there mentally, emotionally, spiritually. It's literally I'm in inpatient treatment. Man, this is the best decision I ever made in my life. My life's turning around. I hate this place. I can't wait to get out here right now. I'm going to cut that guy. This is so good. Recovery's awesome. I've seen the light. I can't wait to burn this place down. I hate you. Oh, it's time for breakfast. Look at that. That's normal, what you see a lot with our clients. Okay. But do you understand that? So listen, if I understand it, that's good because I'm going to be a good helper. Okay. Our clients don't oftentimes understand it. Why do I feel this way? Now you can share with them. This is why. right? This is a medical illness. You have a medical illness, just like diabetes, just like heart disease, just like anything else, that's a result of these things happening to you. Okay, these things happen to you. Um, we want to go back to the optimal arousal zone, right? And hopefully that's where our clients are going to get to. They're going to have more periods of this. And you guys have seen it. You know, you think about the clients that's there their first 5 or 6 days versus 6 months and 6 days. Those two clients usually look very different, right? You know, I used to work at a year-long adolescent residential program. So you imagine teenagers that had to go into treatment court order for a minimum of a year. Okay. And this is back when we had Polaroid cameras, right? So during their assessment, we would take a Polaroid picture of them. And on their graduation day, we would take a Polaroid picture of them. And, you know, we're talking about 16, 17, 18-year-old male adolescents. I've never seen so many of them cry when they saw that second picture. Because the first one, they looked like death on Melba toast warmed over 4 times. Okay. I mean, you could see the addiction, you could see the co-occurring nature of it. But you imagine a year of 6 days a week, weight training, working out, and man, by the time they're different human beings. They feel different, they walk different, they talk different, they smell different, they act different. It's the benefit of recovery, you know. But that doesn't mean their first 8 days or 10 days, you know, they really struggled a lot. And so many of those kids experience trauma. So many of them experience trauma. The more severely we're dysregulated and the longer the dysregulation lasts, the greater the chance we experience unbearable discomfort or difficulty within our own skin. Coming out of my skin, don't feel comfortable, can't sit still, can't focus, can't. And yes, that looks and feels like ADHD, but usually it's not. Okay. In fact, if anything, it's usually anxiety. You know, a lot of people will self-medicate to move away from that feeling. It makes sense, you know, and unfortunately, substances work. Enough alcohol will deaden that. Enough cocaine will get me out of the depression. Enough opiates will disassociate me from it. Okay. Make me pass out. It works. And obviously these are very addictive substances. So there's that too, right? Yeah, there we go. So going to talk a little bit about the brain here. You know, all of us in here, we've got, you know, certain parts. I told you about the hippocampus, but we're going to talk about 4 that when you think about a substance use disorder and PTSD, this is everything. Okay. And if you understand this with your clients, you got a big leap ahead. All right. So you lop off the top of my head and look in the middle. We all have a midbrain. It's called our old brain. It's the survival part of our brain. This goes back to caveman times too. You know, it's the part of our brain that's responsible for breathing, right? You know, it's the part of my brain that has to do with, you know, shelter and all that. But it's also the part that's responsible for managing stress. Okay. Work stress, kids, family, finances, cars, housing, you know, day-to-day stuff, physical things. You know, this is the part of my brain that manages that. Trauma. It's the part of my brain that manages when something traumatic happens. Do I talk to somebody about it? Do I use a substance? Do I do this? Do I do that? So it's huge because once it tags Jack Daniels, Xanax, Darvocet, fentanyl is a great way to manage stress, I'm in trouble. Okay. Because what's its other big job? It sends messages to my prefrontal cortex telling it what to do. And that's huge because my prefrontal cortex is stop, think, and act. Right? I have a quarter pound of weed. I want to get high at school. I'm going to take it to school. That makes sense. Stop, act. Wait. Thinking's coming. Oh, I'm in the principal's office. I got a possession charge. Oh, I shouldn't have done that. See what I mean? My brain's compromised. I have a hard time with stop, think, and act. Okay. And prefrontal is huge. That's the seat of myself. That's my personality. If it's harmed, damaged, that is the neurobiological explanation for why we will show poor judgment and act before thinking. It is absolutely the explanation for it. Okay. Man, I can remember, you know, I'm working inpatient detox, you know, here's a 48-year-old grown male in front of me who's throwing a full-blown temper tantrum on me because I just said that crazy word, no. Okay. Now he's 48, but his age of onset of substance use was 12. So I'm really interacting with a teenager emotionally, cognitively, mentally, spiritually, because of this, what I'm sharing with you guys. That's just the nature of what happens. Okay. So that's huge. We all have a nucleus accumbens. It's real important because it's a part of our brain that has to do with motor behavior. And specifically, it's the part of our brain that designates how much effort will I put into something directly related to the payoff. We have a part of our brain that does that. I want to congratulate all you guys. Your nucleus accumbens worked. You made it to the training. You got a payoff from being here. You got in your car, you drove distances, you got away from work, you had to change things in your schedule because you're getting a payoff. Okay. How many people in here have some type of credential, license, or certification? Stick your hand up. That's your nucleus accumbens. Your nucleus accumbens decided, I want that. I'm going to study. I'm going to go to training. I'm going to read stuff. Heck, I'm going to take a test. I'm going to do this for 3 years, 5 years, and you did it. That's your nucleus accumbens. Now, it gets conditioned to things that have big payoffs, but also things that have little effort. Okay, smoking crack cocaine, tremendous payoff, little effort. Smoking weed, big payoff, little effort. Fentanyl, the biggest payoff you can imagine with hardly any effort. Okay. I used to do work with problem gamblers. Tremendous payoff, little effort. How many people here have children? If you all would let your kiddo play a video game as long as they wanted uninterrupted, how long would they play it for? Okay. That's their nucleus accumbens. Tremendous payoff, little effort. Okay. And our brain starts to get used to that, right? Now let's flip it. First period English, tremendous payoff. So much effort, I skip it. Inpatient treatment. And I would see clients all the time. I remember this one guy, I did the phone intake for him. He came from Pikeville. I'm in Lexington. Yes. Yes. Let me look at everything. Okay. You're approved for the assessment. You're going to get admitted. Come on. He gets in his car. How long does it take to get from Pikeville to Lexington? Okay, he gets there. He waits in our lobby for 2 hours. He goes through a full assessment. He goes through a skin assessment. He goes through a nursing assessment. He finally gets back to the unit at 10 o'clock at night. He's glad to be there. I come in at 8 in the morning. He walks up. I want to sign out against medical advice. Why? His nucleus accumbens. It's too much effort. I want to get high. That's going to be quick. And his brain is conditioned to things that have a big payoff with little effort, even though that effort he puts into the treatment and your clients could save their life. Make sense? So that's what's at play for a lot of our clients, especially in early recovery. Lastly, we all have an amygdala. It's real important because it lights up the cues to the environment that have to do with things that give our brain a payoff. Okay. Kathy sat here, said lunch. If I had all you all cooked up to a PET scan, I would see your amygdala light up because you were getting food. Okay. But it also lights up to cues in the environment that have to do with drug use. Okay. It lights up to all kinds of cues. I had a client I was working with not too long ago. He just came from 30 days of inpatient treatment. And I was talking to him about craving management. And I'm like, so man, talk to me about, man, walking out of treatment. What did they do anything to kind of help you? And he's like, man, the thing that I appreciated so much was when they got into the safe and pulled my phone out, we spent 2 hours processing my phone. I'm like, well, tell me about that. He's like, man, I'd been there 21 days and I turned it on and I looked at the 148 messages on my phone. Okay. And the therapist sat there with me and we started to play them that were all, hey man, where are you, man? I got these OCs. Where you are? One. Hey man, you imagine him walking out, listening to 148 of those. And he said, when I looked at the first name, I got cocaine taste in the back of my mouth. I hadn't seen a drug. Nobody offered me a drug. I saw a name on a phone and my brain had a physical reaction because my amygdala lit up and made me get the taste of cocaine in the back of my mouth. Now, if that's not a brain illness, I don't know what is, but those are the things that it's good to know personally about your client. What's that going to be for them when they walk out of your environment, because their amygdala will do its job. Don't forget what makes you feel good. Don't forget, now it also works toward things that are negative. Okay. If all of a sudden I'm standing here and a snake came out from underneath the stage, this room would change. That would be your all's amygdala. It would light up for things, which means it will light up to trauma cues. It will light up to things that remind me of it. So your clients sitting in group and a client shares about past physical abuse, and some of the other clients start thinking about it, that's what's going on. And some of them might even dissociate. They're going to go back to 12 years old when this stuff happened. And, just be aware that may be going on, and that's going to change their affect. It's going to change their mood. It's going to change their whole outlook potentially, which is why it's good to process stuff. It's good to process stuff every day, especially at the end of the day. How are we doing before we're trying to get my brain to calm down? Okay. But, this is a lot of the pieces of the puzzle about the impact that's gone on with your clients longer term. And also a big part of, hey, the benefit of recovery and how much we can have an impact on changing this, but it also explains a lot about trauma too, and how that plays a role in this as well. Okay. Any of you guys work with people with methamphetamine use disorder? That, man, we're seeing so much of that now. Okay. So now let's talk a little bit about, specifically what we know about the impact of some drugs on brain functioning, and methamphetamine especially. There's some unique things that unfortunately our treatment environments have not gotten caught up to yet. Okay. The meth that's out there now is so pure. Oftentimes it has fentanyl in it. Okay. You guys know that. It's not like the old gas station meth and, all that kind of stuff now. We don't have meth labs. Okay. We don't need that anymore. So the cognitive deficits that are not easy to detect, it has such a big impact on what are typically called didactic educational experiences. Okay. What do I mean by that? A client with significant methamphetamine use disorder, if we think that they can sit there for a 3-hour IOP group and retain any of that, I'll show you a unicorn too. They're not, guys. It's impossible. There's no way. Okay. If you think they can hang out for 4 hours of partial, even with a little break here or there, they're going to struggle with that. Because if you look at a lot of the MRI scans and the effect of methamphetamine and everything else, treatment modalities need to come around to that. Okay. We need to tailor things that are going to address the cognitive issues and the co-occurring mood and everything else. Right. So what's that mean? You're going to be much better served starting a group off with 10 minutes of stretching, breathing. Okay. Just being quiet, letting their brain calm down a little bit. Then something like, I'm just spitballing here, let's pass out some 4x4 note cards. Whatever the group is, we're going to have them all write stuff down. Okay. It's using stuff, eyes, feel, they're going to all share it. Okay. So there's a process to it, or you're going to have them come up to the board and write something and then maybe talk about it. They'll retain that. Okay. But if it's going to be 45 minutes, I'm just listening, man, give it up. I mean, it's, now you're going to go through the motions and it'll get paid for, but will the client benefit from it? Probably not. Okay. So you're better off, and then the other thing is, the benefit that they get from exercise is unbelievable. Okay. What's our brain's role? We want to establish new neural pathways. How do we establish neural pathways? Activity, right? So kind of think about like this. Any of you guys have dogs? I love dogs, right? I got a great dog, right? But not too long ago, she met the dog next door, okay, behind me. And what started happening? As soon as I let her out, where would she go? Right to that corner, okay? And she starts going back and forth, back and forth. What's happening to my grass? It's getting killed, okay? But that's a lot of our clients. The neural pathway has been established. Now we're trying to change that in treatment. And you can change it, but you have to do things to help that change, okay? Now I put a little block thing there and she can't go that way. So guess what? My grass is starting to grow and it's going to look better, but it's never going to look the same. It's better, okay? It'll be better. But can you do things to help them reestablish pathways? And man, an hour of sweating, working out, exercising, huffing and puffing 6 days a week, That'll do it. Weightlifting, any of that stuff will do it. Okay. That's one of the best things you can do and listen, that helps with mood, natural endorphins, natural serotonin that comes from exercise. One of the best things we can do. Okay. Let me kind of put this all up here for you guys to see. So, we talked about this part down here, right? There's triggers, there's cues, there's a payoff. Okay. And when you have trauma, grief, loss, abandonment, abuse, things that are really negative on my brain, situations, fractured relationships, family issues, loss of job, medical illnesses of some kind, difficult emotions, anxiety, depression, stress, anger, hopelessness. Okay. Here comes these behaviors. But then we're starting to look at how do we establish new pathways, new routines for new habits. All right. We want to improve health. We want to improve wellness. We want to have some peace. We want meaning. We want connection. That also gets into the clinical product, the treatment environment, where they are, your program, that may be medication of some kind, be that medication assisted treatment or antidepressant, mood stabilizer, things like that. That's going to be all the things I just shared with you guys. Are you doing some things that have to do with mind, body, and spirit? That has such a huge part to do with recovery. New skills, establishing new relationships. We're pack animals. So, we need to have a pack to run with, so for our clients, and listen, that's the benefit of, and we're going to talk about self-help groups, Alcoholics Anonymous, Narcotics Anonymous, Double Trouble groups. The benefit of having other people that I can relate to has so much to do with improving my mental health and recovery. And for PTSD, it's really significant. So what are some other things that help? Yoga, huge. Okay. Being quiet, my body, being more limber, stretching, breathing is a huge one. Expressive arts of some kind, that's awesome. Music, music therapy, the research shows music taps into a part of our brain that's pretty unique, now that also gets into cues, and it's an opportunity in a safer environment to work with clients through that. Okay. They're going to hear a song and boy, they can have a reaction to it, but let's process that in a safe place. What's that mean for you? What's it like? What are you experiencing? Okay. How can we change that relationship? How can we bring in new things that can be beneficial? Therapeutic drumming, chanting, meditation is a huge one. Can we start the day with it? Can we end the day with it? Can we have some of it during the day at some point? And those are things a client can do completely by themselves. They can do it on their own. It doesn't necessarily have to be in a group or something like that. That can be extremely beneficial. The benefits that come from that, we're trying to reduce ruminating about the past and what happened. It's going to definitely reduce stress. It boosts working memory, which is huge, increases focus, lessens emotional reactivity, which is what we want. I'm talking about co-occurring disorders. We'll get into this a little bit more, but I know a lot of programs are seeing more clients that have schizophrenia, schizoaffective disorder, psychosis, along with a major opiate, methamphetamine, substance use disorder. Okay. For those clients, especially, adding these things is going to help their psychosis. It's going to help their mood. They're going to be more stabilized. Okay. If you don't have it, they're going to be more ramped up. They're going to be more anxious. They're going to be more apt to be volatile. Okay. One of my first supervisors, and he'd done residential treatment for probably 30 years by the time I met him. He said, Geoff, you want me to tell you the secret of residential treatment? I said, yeah, man, tell me. He's like, keep them well fed and tired. Well fed and tired. Maslow's hierarchy of needs. My stomach is full. I'm content and I am worn out. I'm less likely to get in trouble. I'm less likely for heeing and cheeing. I'm less likely for all kinds of stuff, So, and I used to see that every day in residential when I was doing it, more relationship satisfaction, and then all these other health benefits. Okay. Now there's some strong emotions that we tend to experience in our lives, right? Guilt can be a strong emotion, sadness, being upset. Shame is a really difficult one. And for a lot of our clients, they experience this. Merrill Norton, some of you guys have probably seen Merrill Norton. He's going to be back here in Kentucky in September at the CAP conference. So definitely want to come see him. I first saw him in 1998, a long time ago, but he does a great presentation about shame and addiction and the relationship of how shame is neurotoxic. I mean, the research shows that it actually has a negative effect on our brain functioning. So do your clients have these feelings like they're an embarrassment to family, spouse, community, their kids? Do they struggle with that? Okay. Are you trying to help them process that and work through that? Because shame in excess is neurobiologically toxic. It affects affect regulation, and it really affects a very important thing, which is attachment. Okay. My ability to attach in relationships, it gets impacted. Well, why is that important? What's the most beneficial thing oftentimes for coming into treatment is the attachment to treatment providers. My attachment to those people that want to see me recover. If I struggle with that, I'm going to have a hard time in recovery. I'll be the person that goes to a meeting and I just hang out, and I'm in the back. I come in 5 minutes late. I leave 5 minutes early. I really have a hard time with going up and creating an attachment. And oftentimes that's related to trauma too. With neglect, rejection, okay, shunning type behavior, the amygdala, we just talked about the amygdala. It understands relationships as being unsafe. Okay. It understands relationships as they're unsafe. And that's huge, because you all know, I mean, man, sponsors are a big part of recovery, but if I feel unsafe in it, I'm not going to get one. So do you explore that with clients? Is there apprehension about that? What might that be about? That's important for us to understand that. Shame interactions in conjunction with a lack of relational repair leads to humiliation. Such a state is proposed to be toxic to the developing brain. A lot of our clients, when you think about complex trauma, so I experienced a loss, or I had somebody that I normally look to for love, trust, they're not present, they're absent, or they've abused me. Boy, you talk about shaming interactions, that's a big one, so helping them process through that, get to a different place with it, a different understanding about it, how they view themselves, that's such a huge part of recovery for that person, that if they can address that while they're with you, man, their chances of long-term recovery are going to go up pretty significantly. Judgment, silence, secrecy oftentimes comes along with that. I was doing supervision yesterday with one of my supervisees, and she was talking about a male client she started working with, and he won't share what happened to him. He just shares, I can't stop thinking about what happened. I can't stop thinking about what happened. And she tried to ask him about it. He's like, if I talk about it, it makes it too real. Okay. So what's happening with him right now? He's sober. It's the most sobriety he's had in probably his whole adult life. And, our brain is kind of like this. You have these experiences and you keep putting them in a drawer and shutting it, putting it in a drawer and shutting it. And eventually that drawer is going to fly open and you can't shut it anymore. And right now for him, he can't do it. And it makes sense. He's feeling way. The difficult part is trust. Will he trust her enough that he can share it and it's going to be okay? That he can actually start to process it and normalize it and change some of his thinking about it to where, man, he's going to get better. And that's what she's going to try to do with him. Okay. But that may take a while, I think we figured out, it's been like 16 years since all that happened, 15 years of that using substances. So he's in a place he's never been before, which is pretty scary, But if she uses this, empathy is huge. We all like to be empathized with. We like it when somebody asks us, hey, how you doing? You doing okay? How's your day going? We like that. Our clients need that. Do we have empathy? Do we have compassion? Do we demonstrate genuineness with our clients? And you think about being in a recovery group, such a big part of that is empathy, inclusion. Come on in, we all want to go to a place where everybody knows your name. That's what's great about recovery groups and being in treatment oftentimes is, I'm going to get some empathy. I'm going to get some compassion that can be really beneficial for them. Some of you guys, probably familiar with William White. He wrote the book Slaying the Dragon, which is the history of addiction treatment and recovery in America. If you ever get a chance to check that book out, it's really insightful. It's a great read. But William White was one of the first people to really talk about the benefit of recovery capital and how do we do with helping our clients improve their recovery capital while they're with us. So when you think about financial capital, okay, hey, we want to be wealthy. Well, that means we need to add stuff to be wealthy, okay? Think about the same thing with recovery. And I'm always thinking with my clients, how can I improve their recovery capital? So that gets into things like, have they completed something? And if I graduate high school, that's recovery capital. If I got my GED, that's recovery capital. Jobs, have I had jobs? Skills, that's recovery capital we can tap into. Education, that's recovery capital. But also, can I add that to them now? Can I expose them to education, job training? All that's going to be recovery capital. Employability, we've talked a lot about that today. That's huge. I mean, the research shows one of the biggest benefits that can come into recovery is I have a place that I have to get up for, get ready, go, be there for several hours, interact with human beings. Maybe somebody will say, hey, you did a good job today, and I get paid for it. That is a huge part of recovery. It's a huge part of who we are, So for our clients, man, that's a tremendous piece of recovery capital. And that's why it's good that we're moving the ball down the field with felony expungement. How do we change that for our clients? How do we open up more doors for them because of the consequences of their substance use disorder? Insurance. Do they have Medicaid? Can they get on insurance? That's recovery capital. Housing, everything that Jonathan talked about, that's recovery capital. Learning communication skills, family support. You all heard me talk about being a family therapist. Lots of times our clients I've worked with, they would burn bridges with family members, okay? But almost inevitably, there were some people that were just waiting. They were there. Maybe they hadn't thought about them, or maybe they hadn't seen their uncle in 4 years. They hadn't talked to their aunt or their cousin or whatever. But once they reestablish that relationship, it's huge. It's a huge piece of their recovery, but there's fear and shame about, hey, what's happened? How am I going to be viewed? But if we pick up the phone in a session, we call them, they have a conversation, next thing you know, they're hanging out. Man, it totally can change their recovery. Any involvement in pro-social community groups, huge addition of recovery capital. Religion, spirituality, church, faith, reestablishing culture, ethnicity, religion. For a lot of our clients, that can be not only a huge part of recovery capital, but a part of their shame. So we can address two things at the same time with return to culture. And I mean, there's so many other things, but thinking about that with your clients, every time I interact with them, how can I make them richer? How can I add to their recovery capital? And if you're doing that, you're doing a good job. So let's talk a little bit more kind of in depth here with co-occurring disorders. When you think about the history of our field in treating co-occurring disorders, it hasn't been the best. Okay, we've gotten better, but back in the day, and especially when I'm talking about 50s, 60s, 70s, even 80s, we did what was called sequential treatment. Okay, so let's picture somebody with major depressive disorder and cocaine use disorder. What used to happen? Well, they would go to one place and get help and totally ignore the other. So come on into psychiatric treatment. We're not going to even talk about cocaine. We're just going to work on your depression and not being depressed, and then think that when you walk out, everything's going to be great. Or we would do the other. Come on into treatment. We're going to get you sober. We're not even going to talk about your mood. You're going to be deeply depressed. and leave treatment, and what's going to happen? I'm going to relapse. But that was sequential treatment. Okay, they didn't happen at the same time. Very flawed, but happened all the time. Then we wised up and we started doing what's called parallel treatment. When I came into the field in the early 90s, parallel treatment, okay? We go to this building to get help for my substance use. We go to this building to get help for my mental health. And I go to that building for my medication. And hopefully the three people talk to each other. Now, if they do talk to each other, it can work. Unfortunately, that doesn't always happen. And that can still happen now. And listen, that it can work. It can definitely work as long as people are talking to each other. Ideally, we want to get to integrated treatment, which is I'm in one place. I can talk to Geoff about my bipolar disorder and my opiate use disorder and methamphetamine use disorder. If I need medication, Dr. So-and-so is down the hall. And we talk in a treatment team meeting once a week. That's kind of the gold standard. If that can happen, that's great, because recovery will happen in a more consistent fashion. Clients' needs will be addressed. And, listen, even things like triangulation don't happen as much. Okay. I'll give you an example of that. I had a doctor call me up not too long ago. He's a primary care physician in Lexington. And I've got his client, right? He knows that, and we've got to release information. He's like, looking on my phone, I see it's him. And I'm like, hey, Dr. Johnson, how you doing? He's like, Geoff, I'm doing great, man. Listen, I just saw, our guy so-and-so, and I've known you for a long time. So I know when I say this, you're going to laugh at me. Okay. But he did come into his follow-up appointment. He said, listen, I saw Mr. Geoff, and he said, because I'm anxious, I probably would benefit from Xanax. And I said, well, I've known Geoff for like 10 years. He's on the Alcohol and Drug Counselor Board. I don't think he'd say that, but so let's just hold off, okay, and wait. Okay, he's addicted to benzodiazepines. I'm like, no, Dr. Johnson, I didn't say that. He's like, that's what I figured. Okay, what was happening there? Triangulation. I'm going to tell this person this, and that you said and that's okay. That happens. That's a part of the illness sometimes, but we can effectively treat him because we're talking. Okay. And again, cross-trained, you guys are getting this training today. That's great. Responsive to the many changing symptoms that come along with clients, especially clients with post-traumatic stress disorder. That's going to be beneficial for them. So Kenneth Minkoff, he's kind of the godfather of integrated treatment. When substance use disorders and psychiatric disorders coexist, each disorder should be considered primary, and integrated dual primary treatment is recommended, where each disorder receives appropriately intensive diagnosis-specific treatment. Appropriately intensive diagnosis-specific treatment. So like you guys probably know, every year SAMHSA does their huge survey. You guys have probably gotten it. Okay, what are they trying to do? What treatment programs are out there? What type of services do we have? What do you provide at your treatment program? Okay. One of those last surveys, I think it was 2022, looked at inpatient residential, right? And in that survey, what they found was 53% of substance use disorder treatment programs provided some type of co-occurring group session something. Okay, so that's not bad. But that also means almost half of them, clients that have a severe medical disorder, are going to go there and not get what they need. Nobody's going to say, hey, have you ever heard of co-occurring disorders? You have one. And let me provide you with some education and some treatment about how to manage these. Okay. Now, a lot of you guys have that. You got a doctor there, they're prescribing medication. When they see the therapist, they're talking about both. They can talk about a group. That's great. That's what you want. And maybe you even have a co-occurring disorder group where once a week we talk about that. That's even better, okay? Or if you have an actual double trouble group, right? NAMI's started double trouble groups. We've got a bunch in Lexington, okay? That's a group where I can go and talk about my bipolar disorder and my cocaine use disorder and my medication, and that's the norm. That's what you're supposed to talk about there. And if you want to start one of those, hit up your local NAMI chapter and they'll help you start one, because that's a great group to have. But this is kind of the gold standard of, what you want to be providing in your treatment program. Client participates in a program that provides treatment for both disorders. Mental health and substance use are being addressed by the same clinician, ideally. We're trained in psychopathology, assessment, treatment strategies for both mental health and substance use, okay? And let's take that a step further. Do we provide things like EMDR? Do we provide trauma-focused cognitive behavioral therapy? Okay. Do we provide ART, accelerated resolution therapy? Those are evidence-based clinical practices to help people that have PTSD. Not everybody can do that. Not everybody has that type of provider, but that's really helpful. Listen, if you're involved in the VA system, there's going to be somebody that can provide EMDR. I mean, that's just the VA gets it. The evidence is behind it. Man, they've got it instituted in every substance abuse program they have because they know the benefit of their soldiers that get EMDR. Substance abuse treatments tailored for clients who have severe mental disorders. And we're seeing, I'm sure you guys have seen this too, but the increase of clients that are coming into inpatient and residential that have more chronic mental illness and significant substance use. And even now, medical issues, more complicated medical issues that are coming from both of those disorders, oxygen tanks, wheelchairs, rollers, all kinds of things that are going on that are a result of some of the issues they've had. So clinicians available, 12-step groups are available, neuroleptics, other pharmacotherapies are indicated for those that may need them. Now, I will say this, there's definitely a percentage of clients that will come in, their mood is affected, but they probably fall more in the substance-induced mood disorder. Okay, so here they are, let's give it some time. After a month, how are you feeling? After 2 months, after 3 months, 3 or 4 months, they're not depressed anymore. They're not as anxious. They feel better. By the time they get to 5 to 6 months, they're stabilized. The effects of their substance use have worn off and their mood has gone back to a normal coping state. And a lot of clients will experience that. We're talking about the clients typically that aren't going to experience that. They've had a long history of mood disorder going way back, even before their substance use, or they experienced trauma before their substance use. Much more likely that they're going to benefit from that. Why else do we want to think about integrated treatment? Okay. So one of the most common causes of psychiatric relapse. Okay. I'm stabilized with depression and I get worse. I'm stabilized with my mood swings and now they're back. Is I used a substance. Okay. I had sobriety and I smoked a joint. I ate a Darvocet. I did this. Okay. So that's a huge risk for my stability. Let's flip the coin. One of the biggest precipitants of relapse on substances is untreated psychiatric disorders. So I'm in your program. Here I am getting ready to check out. I'm coming out of my skin. I'm not talking about it. I have severe anxiety and I'm going to drink again because I haven't treated my mood, So that's why it's really beneficial, especially in like inpatient or residential, that we can stabilize their mood while they're with us. Their risk of relapse goes down pretty significantly if we're doing that. Some of you all might have seen this model. It's called the Quadrants of Care model. This is from the National Institute on Drug Abuse. That's a really specific way to look at co-occurring disorders. Okay. And as you see here, we've got 4 quadrants, right? The one that's in yellow there, hey, look at that. What you see there, quadrant 1, low substance use severity and low mental health disorder severity. Now, listen, that is a person with co-occurring disorders, but what's that look like? Here's somebody that's going through a divorce, an adjustment disorder, and their drinking's increased. They're having 2 glasses of wine in the evening, 3 or 4 on the weekends, so a little bit of binge drinking. They're going to work, but they're impacted, okay? They meet the criteria for a mild substance use disorder and a mental health disorder. A lot of those clients will show up where? Primary care physician office, nurse practitioner, okay? They'll present for a physical issue and start talking about what's going on. They'll show up in my office. I'm an outpatient provider, right? But they definitely have co-occurring disorders. They may have generalized anxiety and they're smoking weed to cope with it. And that's starting to impact, they don't like how it feels. They don't like that they're doing it. They're using more than they're used to. Maybe it's impacting a relationship and they want to get some help with it. Okay. To the right, quadrant 2, low substance use, high mental health disorder severity. low substance use. I'm binge drinking, right? And I have schizophrenia. I'm smoking marijuana 2-3 times a week, and I have bipolar disorder. So it's going to impact my medication if I'm not careful. I may occasionally use cocaine. I drive when I've used it. So boom, I'm hitting a mild substance use criteria. And I have bipolar disorder, or I have major depressive disorder. That would be a quadrant 2 client with co-occurring disorders. Upper left there, okay, the brown, high substance use severity, low mental health disorder, high substance use severity. It's probably been about a year ago. I had a new client. Okay, I looked on my schedule. He comes in, big guy, 6'4", probably 230. All right, sits down on my couch. I'm like, hey, talk to me about, how you got here when my wife wanted me to get help, tell me what's going on. He's been a computer guy at the same company we would all know in Lexington for 22 years. Okay, rarely misses a day of work. What is it your wife really wants? She wants me to talk to you about my drinking. Oh, okay. Well, tell me a little bit about that. Well, I drink probably 12 beers a day. All right. Is it more on the weekends? Yeah, sometimes 16. And he's sweating on my couch and his face is red. I'm like, well, Barry, like, when's the last time you had a beer? 24 hours ago. What's he doing on my couch? He's going into DTs on my couch. I'm like, Barry, we need to get you to a detox unit. He has a severe substance use disorder, but his mood's a little depressed, but he's, for the most part, functioned okay. You see what I mean? And there's other clients, fentanyl, methamphetamine, but upon stabilization, they might have an issue with their mood, but it's not like bipolar disorder. It's not schizophrenia. It's lower. Okay. Then you get quadrant 4, high substance use disorder, high mental health disorder. Okay. Schizophrenia with opiate, methamphetamine use disorder, schizoaffective disorder with borderline personality disorder, and a couple, those are individuals oftentimes that will show up by law enforcement. They'll show up at a jail. They'll show up at Eastern State or Central State Hospital or an emergency room sometimes. But I share this with you because that gets into, who do I have in front of me? What's going on with them? And what do I need to focus on with them? Okay. I'll admit, as a substance abuse provider early in my career, I tended to focus more on the substance use, less on the mental health. Okay. Now, yes, that gets into things. What type of license do you have? Can you provide those types of services or not? And if you can't, that's okay, but make sure they get to a person that can, right? So if I'm a CADC and I'm focusing on that, but I recognize, okay, you're talking about auditory hallucinations, I need to make sure they get to a mental health provider. And then we can work together with them, right? Or to a physician or a nurse practitioner. But this is just another way to think about the clients that you're working with. So in residential treatment, who do you have in front of you? Is quadrant 3 client, quadrant 4 client? That's helpful to be aware of that. All right, we're doing okay here. Questions about anything I've covered up to this point? Everybody seems awake, so that's a good sign. Okay, all right. So some guiding principles for treating clients with co-occurring disorders. There's 6 I'm going to share with you all. And if we're trying to do this, we're going to do a good job, right? Number 1, employ a recovery perspective. Most of you guys do this. We know recovery is a long-term process. A lot of our clients, it took years and years before they came through our front door. Even the quadrant 1 clients I see, I had a lady the other day, she was 35, okay, anxiety, she doesn't like her drinking. When did you first notice issues with your mood? 14. So 21 years, she's fluctuated with her mood. When did your drinking stuff start? Middle of college, 20, 12, 13 years. You see what I mean? Have you ever seen a provider before? No. So hallelujah, I'm glad she's here, but that also means she's been going along for a long time. So it makes sense in the beginning. It's probably going to be a little rocky. We're talking about your brain giving up something potentially that I've had a relationship with for years, which also gets into understanding that our clients are going to go through a natural grieving process when they decide to stop using substances, just like when you lose a loved one. If I've had a relationship with narcotics for 18 years and I'm going to divorce it, man, I'm going to be pissed. Just like I lost a loved one. I'm going to be angry. I'm going to be severely depressed and sad and upset. I'm going to want to barter. Can I use pills? But eventually I might get to acceptance. And that's where recovery can start. It's real similar. Okay. But do you do a group talking to your clients about grieving their substance use loss and what that's like? Recovery is long-term. It recognizes the changes and that this goes through stages. So we want a treatment plan that also provides continuity of care over time. Okay. Initial stabilization, acute stabilization, engagement, actually starting treatment. So if we're doing this, and that gets into things around their mood, post-traumatic stress disorder, and their substance use. Number two, adopt a multi-problem viewpoint. Our clients that come in, there's a whole array of problems, and this gets into the recovery capital part. I may have been homeless for a year. I haven't had insurance. I just got Medicaid. I'm just now addressing some significant medical issues. So I'm going to the hospital. I'm getting X-ray. I'm getting stabilized there. I have sleep apnea. I've got this. Housing, we're thinking about sober living, employment, some of the biggest aspects of our lives, a lot of different problems, so if we can address those, man, that's so cool. And that's going to help their chances of recovery. But, let's take a step back and recognize it's a pretty daunting task. So that's where things like case management, peer support specialist, are such a huge part of the treatment support for our clients, that we want to bring those in to try to help them daily, weekly, monthly with these things. Lots of times we talk about, we're going to refer a client to rehab. Okay, well, what's rehab? Rehabilitation implies I had a skill set, I got away from it for my drug and alcohol use, and now I'm trying to get back to it. That's not a lot of our clients. A lot of your clients, it's habilitation. I never had the skill set. I started when I was 13. I never got these coping skills. I don't have so you're really starting with habilitation and learning things for the first time. So do you have parts of your treatment that address that with clients? Because if not, what may happen is, well, why don't they get their assignments done? Why don't they show up? Why aren't they motivated? Well, hold on a second. This is probably more a skill issue. And I just don't want to tell you I don't have the skills, So what's better for me? Don't show up. So don't assume that that's what it is, when actually it could be, this is habilitation. It's going to take me 6 months, a year to kind of get back to where my normal level of functioning might be. Develop a phased approach to treatment. Clients do typically progress through phases. The phone rings, they walk in. Okay. And what starts right then? Engagement. How do you greet the client? What's the first thing you say to them? How do you interact? Do we use empathy, genuineness? Do you try to make a connection? Does it feel warm? Does it feel comfortable? Does it, and listen, that even gets into things like, what's it look like? What's it smell like? What's it feel like? What's it sound like? All of that stuff. We're sensory driven animals. Okay. So, this room's pretty comfortable, but if it got hot, I would definitely lose some of you. Okay. If it started to smell in here, you'd want to get out of here. There was a loud banging next door, you all would start getting pissed. What's your treatment program like? Right. When I worked inpatient psychiatric, so you imagine walking into an inpatient adolescent boy psychiatric unit with age 14 to 16 boys that don't like to shower. What's that smell like? Okay. And they've just gone to rec therapy. So if I'm doing my rounds and I show up on that unit, I'm picking up the phone and I'm doing 3 things very quickly. Housekeeping, number 1. Number 2, I'm cranking on the air conditioner. Okay. And we're spraying Febreze everywhere. I want it cold, smelling better, and calm. Because if I don't, what's going to happen? A fight quickly, because we're sensory driven animals. So what's your treatment environment like? What's your office like? If you're an outpatient provider, what's it feel like? What's it smell like? Okay. What's it look like? If you want your clients that have PTSD, especially, they have an issue with connection. So when I walk in, does it feel like I want to make a connection here or not? Or is it stale? If they can hear other clients talking in the room next to you, that's not good. Get a sound machine. You want to make sure that the environment, elicits their senses in a positive way. Now see, right now I'm sitting here, my amygdala is thinking about a soft drink. Used to be some over there. Address specific real life problems early in treatment. Okay. Interventions that target important areas of client need. Clients with PTSD, bipolar disorder, psychosis. Okay. How quickly are we recognizing that and trying to treat it? If I'm in your group and I'm having auditory hallucinations while I'm trying to listen to you and other clients, that's going to be tough. My brain's going to scream, go get high, go get high, go get high. So do I need Depakote? Do I need, Risperdal? Do I need Zyprexa? Do I need a psychiatric evaluation? Or, hey, do they want to, and it's okay, give this time to see, does this change as I get stability? But if you start to see a client get to where all of a sudden they're getting aggressive, hit the brakes, because you're going to be responsible for that. You're going to keep them in a churning environment with a medical issue that's not being treated. Okay. So they might need to treat that. A couple of doctors I know that are ASAM docs, they've talked about, especially with fentanyl and especially with methamphetamine, they've kind of changed their view from, instead of let's give this a lot more time before we address it, what they're finding is if we don't treat it, they're going to leave against medical advice. I would rather try to address it early, and if I need to, back off of something, but they're stabilized and they're going to be okay in that first month and hang out, because they've seen, one of them specifically, she's like, I have lost fatally clients that left against medical advice and overdosed. And I think we waited too long to try to treat their co-occurring mental health disorder. Okay. So we don't want to do that. Psychosocial rehabilitation, we kind of talked about that. That helps clients develop specific skills and approaches to perform chosen roles. That gets into, hey, what skills do they have? Because all clients have skills. Man, they've had maybe jobs before, abilities, things they've done, things they've completed. And listen, some of them, a huge one is they had a prior period of long-term sobriety. Clients that had 4 months sobriety, 6 months, 12 months, 18 months, they'll view that sometimes shamefully as a failure. I always view that as, that is huge, that's success, and we need to tear that apart and use some of it now to help you. Okay. So don't look at that as, there's clients that would give anything for 4 months. You've had it. So let's shine a light on it in a positive way and figure, I want to know everything about it. Who, what, where, when, how. Why did you achieve that? Doesn't matter if it's court ordered, not in jail, in residential, that you did it. So let's use it now. Okay. Solving problems reinforces engagement. Solving problems reinforces engagement. Housing, where they're going to go after this. Employment, getting a sponsor, support groups, the more problems we can solve, that's going to be beneficial for them. Plan for the client's cognitive and functional impairments. With co-occurring disorders especially, and the impact on brain functioning, you heard me talk about habilitation. We really need to keep that in mind. Okay. It's good to do gradual pacing. Repetition is your friend. Repeating things often, similar messages in groups, trying to ingrain things, that's going to be much more beneficial. I like to hand things out. If a client leaves your program and they got a folder filled with all kinds of information, yes, it could end up in your trash can outside in the parking lot, but that's okay. At the end of the day, though, there's a much greater chance that they're going to refer back to some of that and remember it. And that's what you want. A lot of stuff. And listen, here's the thing. I come find you guys a week from now. All right. And y'all look pretty stable. Okay. But you're only going to remember about 15% of this at best, especially if you don't write anything down. Our clients, man, especially in early recovery, you get done with a group. Well, if you want to do a test at the end of the night, go up to them and say, hey, what do we talk about in relapse prevention 11? That's just normal early recovery. Plus I have bipolar disorder and I've got 2 weeks sobriety and I just started Depakote. I'm a little cloudy. So, I'm not going to remember that. You know, that's like, I got a unicorn I'll show you. I mean, so hand things out, hand out information to them, bring it back the next day, review it, repetition. Clients do better with that. Gradual pacing. In Vietnam, during Vietnam, okay, at one point, 20% of all United States soldiers were addicted to heroin. That's true. Okay. When those soldiers came back after a pretty significant length of time follow-up, what percentage were addicted? 1%. We went from 20 and reduced it by 19%. Now, let me ask you guys, how did we do that? What happened? They did go back to their normal life, but what does that imply? What was helpful about their normal life? Family. Okay. Look at that picture below. You know, that's a pretty famous picture about, you know, a soldier coming back. Okay. Connection. Connection is huge. Now, we also took them out of trauma. I took them out of one of the most traumatic environments you could possibly imagine a human being going through, and brought them back to an environment that, regardless of probably where it is, it's not going to be like that. So that makes a big difference, right? But at the end of the day, going from, you know, this situation to connection, okay, that's huge. You know, that makes a huge difference. So don't underestimate your role in that. And when you walk in the building, okay, how do you present yourself? You know, do you walk in with a frown on your face and, man, I don't want to talk to anybody and all that stuff? That's not going to be the best. If you walk in and, man, you got a smile on your face and you're ready to be there and, all right, man, how you doing and all that connection is huge for your clients, you know. And listen, it's you, other staff, the other clients there, case manager, peer support, directors, clinical directors. And that's where, you know, staff can make and break that. Anybody ever worked with a toxic employee? Okay. You know, the one where you're like, please, Lord, let him fire him. Please, Lord, let him fire him. Please, let, you know, where it's like there's something going on with that man and the clients are reacting to it. Okay. There's something that's happening. And unfortunately that can occur. Yeah, it can occur in any work environment, you know. But you know, Johan Hari, wait a second, go back. Yeah. His book, Lost Connections, why you're depressed and how you can find help. He really talked a lot about how, you know, what's the opposite of addiction? Connection. You know, the more that we focus on how people connect to other people has a huge part to do with recovery. And it's why, you know, when you think about, you know, soldiers, first responders, when I can get into a group with other people that can relate to me, man, that has such a positive impact on their mood, on their sense of self, their purpose. It challenges negative schema and cognitions. But it's another reason why self-help groups are such an important part of recovery. Okay, so the last principle there, use support systems to maintain and extend treatment effectiveness. AA, NA, double trouble groups, in your own voices. Family can be a part of that, supportive family. Faith can be a part of that. The community can be a part of that. You know, a lot of clients, and especially those that are more the quadrant 3 and 4, that might have personality disorder, more significant mental health, they tend to have fractured relationships, you know, and they're going to have to start over in a lot of ways. And sometimes one of the best places to start is the recovery community. It's the environment with you, it's aftercare, it's the recovery community, then it becomes job, it becomes sober living, housing, and man, they can flourish and take off. But you all, this room plays a huge role in that. So, you know, I applaud you guys for the work that you're doing and being a part of this. You play such a huge role in people's recovery. But that part about connection, you know, that's a significant piece of this. Okay. Long time ago, 1989 was one of the first research studies to look at what type of treatment is most effective in substance use disorder treatment. Okay, it's called Project Match in 1989, largest study ever conducted on the treatment of problem drinking. And what do they want to find out? Okay, what type of therapy shows the best results in helping people not only get sober, but stay in recovery? And they picked three: cognitive behavioral coping skills therapy, motivational enhancement therapy, and 12-step facilitation therapy. Now, here's a room full of providers, okay? Which one do you think had the best results in clients recovering? May I take a guess? I see a three. Anybody else? One, got a two, got a three. Okay. What did they find from this? Okay. What they found was all approaches work equally well with some people some of the time. That's what they found. It was almost a third, right? Some treatment works for some people some of the time. There were two things, though, that played the biggest role in people achieving early sobriety and long-term recovery, right? One of them we have no control over. The first one, though, is what's called caregiver allegiance, therapeutic allegiance, which is, does the client think that you think you can help them? Does the client believe that you believe you can help them? If they do, they'll stay engaged with you. They'll hang out in the program, they'll interact with you, they'll handle difficulties because they believe in the relationship, okay? The second one that we don't have any control over is, what stage of change are they in when they get to your place? If I'm in pre-contemplation, I don't have a problem. The only problem I have is I'm here. That's going to be harder. Now, that doesn't mean, man, they can absolutely recover, but that's more of a challenge. They're more likely to sign out, okay? If I'm contemplating change, I'm more likely to hang around. If I'm preparing for change, I'm definitely, especially if there's the other one, I feel like you guys want to help me. You're not just here to get a check. You actually, this is what you like to do. Okay. So I think that's interesting because, man, when National Institute on Drug Abuse throws $10 million at something to try to figure something out, and that's what they came out, okay, that's a big deal, and that's good for us to know and trying to help people. Last thing, here's some evidence-based therapy approaches for trauma. I shared some of these with you, but, just being able to have a person that can provide this for your clients can make a huge difference, especially those that have more significant PTSD, that, man, they're talking about night terrors. They're talking about coming out of their skin. You can tell they're struggling with it. Processing helps. There's a lot of other things we can do to help them as well, psychiatrically too. But if I can expose them to CBT, trauma-focused cognitive behavioral therapy, EMDR, that adjunct usually makes a big difference. They're less likely to sign out against medical advice. They're more likely to stay engaged, and they're more likely to enter into recovery. Okay. Last resource I'll share with you guys. This is tip 42 from SAMHSA, substance use disorder treatment for people with co-occurring disorders. This is free. It's a free resource catalog. It's got every therapeutic intervention, all that kind of stuff. If you're going to try to print it off, I warn you, have a lot of paper and a good printer because it's a lot. But you can get on SAMHSA right now and get 5 of them sent to you for free. It's a good resource, a lot of great information, some of which I shared with you guys today. Okay. Spirituality, and that's the thing. Here's a room full of spiritual people. I mean, you usually don't get into this field unless there's something about helping somebody and lifting their spirits, and it's not only who you are as a person or as a caregiver, but it's the impact that you're going to have on other people, right? So you want to help clients with focusing on pro-social, pro-recovery, pro-spiritual activities and bringing that in and using that to help them, because a lot of those tenets go a long way with co-occurring disorders. Stabilization. What do I want? Peace, serenity. I want to let go of some things. So don't forget that, this is an important aspect of recovery that you all bring to the table. Okay. No ifs, ands, or buts about that. There's a list of resources here. There's my information. Last thing I'll plug to you guys. Okay, you heard Kathy say I'm the president of CAP, which is the Kentucky Association of Addiction Professionals. What's CAP? CAP is the state affiliate for NADAC, the National Association of Addiction Professionals. It's the largest advocacy organization in the country. All kinds of free education that you can get if you need CEUs. We do a conference every year. Our 5th one's coming up September 10th through the 12th in Lexington. Okay. If you're a CAP member, you get half off, which is almost identically the price of becoming a member of NADAC. Isn't that a coincidence? I'm not selling Amway, guys. Okay. But that being said, it's almost a wash for you. And at our conference this year, big deal. Meryl Norton's coming. Okay. Janice Gabe is coming from Indianapolis. She's one of an adolescent substance abuse gurus in the country. Cynthia Marino Tui, who's the former executive director of NADAC, is coming. Terrence White, who's the new executive director of NADAC, is coming. And we got a lot of great presenters that are going to be there. You should come. All the cool people will be there. That's all I got. Thank you all very much.